Good afternoon, everyone. Thank you for attending the MAC meeting. We will just give it a few more minutes before we get started. Did want to know if you are a committee member, if you would put your name in the chat. And if you, it looks like we don't have anyone on the phone yet, so we don't have to have them unmute if they're a community member on the phone. Looks like we're just waiting for Jennifer Marchant to join, and we should get started here in a few minutes. Thank you. Again, thank you all for joining. We've had a couple more people join the call. We will get started here in just a moment. If you are a committee member, if you would put your name in the chat. We should get started here in just a few moments. If you are a committee member on the phone, if you would unmute yourself and let us know that you are here. Thank you. Okay, and also we've had a couple of changes to the agenda. I will let Jennifer Marchant go over some of those. But Jennifer, since we're not doing meeting minutes for May this month, we don't need a quorum, so you can start whenever you are ready. So Jennifer Marchant, if you are talking, we cannot hear you.
Hi, Jennifer. I think you unmuted yourself. I don't know if you can hear us, um, but we're still not hearing you speak. And I'm wondering if there's a couple options. Maybe it's your microphone that's not allowing you to speak. We could have you call in as well. That's another option. We still can't hear you. Um, so I'm gonna paste the phone numbers in the chat window if that would help. You can see I guess it's the third line of what I entered. You'll just have to dial that phone number and then enter the PIN number.
So again, hello, everybody. While we're waiting for Jennifer to connect by phone, if you are a committee member, if you would, please put your name in the chat. If you are a committee member on the phone, if you would unmute yourself and let us know that you are here. I just want to bring attention to a couple of items. We're not going to have a vote on the meeting minutes for May, so we will do those next time. Also, for the nominations for the 2 appointments, we're actually, Michael Jensen has decided to stay on, so he will continue to be the consumer representative for the Native American communities. We are accepting nominations for beneficiaries to replace Luis Rios. So let's see, Jennifer, have you been able to connect, or can we hear you? And if we can't get Jennifer's technology figured out, Joey Hannah, are you on?
I am.
Would you be willing to step in and chair this meeting if we can't get Jennifer's either her to call in or her mic
Yes,
to work?
I will most certainly do the very best that I can. You bet, Sharon.
Wonderful.
We could try one more thing if you don't. Jennifer, I see you trying. So you can press *6 on your phone. That may unmute you. And
Can you hear me now?
yeah, now we can hear you.
My apologies. I cannot believe the technical difficulties I'm having today. Let me adjust the audio here because as I speak, I can hear my voice back in a delay. So it's a little bit confusing. Okay.
Sure, no problem.
All right. Sharon, should I just go ahead now and start the meeting?
Yes, absolutely. Thank you.
Okay. All right. Hello, everyone. I'd like to welcome everybody to the June MAC meeting. My name is Jennifer Marchant, and today I'm temporarily filling in for Michael Hales. I believe he will be back in July. As Sharon was stating, I don't believe she received the May minutes, and so therefore we're not going to need to, I'm not going to need to entertain a motion to have them approved. Is that correct, Sharon?
That is correct. We will do those. We'll do the May and June minutes next month in July.
Great. All right. And so moving on, for those who are just joining, again, welcome to the June MAC meeting. I'm Jennifer, temporary filling in for Michael Hales. As this is my first time facilitating, Sharon Steigerwald and Jennifer Strohecker and maybe Joey Hannah, thank you so much, Joey, are on standby to assist with any questions that may pop up during the meeting. Today we have a lot to go through. The first item I will come back to, the main highlight will be the voting to prioritize ranking of the budget proposal initiative. They were all presented at the MAC meeting in May, and I'll be prepared to run a discussion on those for your convenience if you haven't voted yet, but we will get to that in a minute. At this time, as Sharon was saying, as I was trying to get my phone to work, at first we were going to have nominations for 2 appointments, but we only need 1, is my understanding at this time. Michael Jensen was able to stay on for his 6-year appointment for the consumer representative for Native American community. And so no nominations are needed at this time. What I have here in front of me is we are accepting nominations for the appointment for Luis Rios, who is, let's see, we're looking for the consumer representative for the Hispanic community and criminal justice system. So Sharon, how do I go about the nomination process?
Yeah, so if anyone has somebody you would like to nominate to serve on the MAC committee, if you would please have send me their contact information. And I did put my name or my email in the chat, but I will do it again. You can just email me with your nominations and then I can contact them and get the process started for accepting the nomination. So this one is for a consumer representative for beneficiaries, replacing Luis Rios. So thank you.
Okay, okay. Thank you for clarifying that. Moving on to our second agenda item is the discussion I was just talking about. For the presentations we had in May, there were 15 of them. And if you haven't voted already, you will have the opportunity to vote and rank them in order of importance and get them into Sharon. She will share the results at the end of the meeting. Sharon, would you like me to go over some of those presentations for the benefit of the group?
Sure, if you would like to. Yeah, this is just the time for you all to have a discussion. Any questions? I believe we do have some of the presenters on the call too that can answer questions if anyone has them. And if I can just state one thing, that only committee members can vote. I have received a couple of votes from non-members, and while thank you for your feedback, only committee members can vote. So they can vote via red cap survey, or they could email me today within the meeting the ballot on an Excel spreadsheet. So thank you. Go ahead, Jennifer. You can go over those presentations that we had last month.
Okay. We had 15 presentations last month in May. I will start with the first one from last month. And forgive me if I mispronounce someone's name, feel free to correct me. I have on here that we had Tina Purcell from the Utah Parent Center. She was giving a presentation about the tech-dependent waiver for equitable choices. Pardon me for the pause here. Yes, the tech-dependent waiver 9195 for equitable choices for those who are tech-dependent to have opportunities to live and work. If Tina Purcell is on the call or Gina Polamani, go ahead and jump in if you would like to add more to this.
Hi, this is Tina Purcells.
Hello.
Hi. I'll just expand a little. We are asking for your consideration, please, to prioritize us as a population that is segregated within the HCBS waiver that they are in. There's not necessarily an option at all for them to be independent adults without someone that can care for them in a skilled nursing level. And so a lot of the time that is a family member that's aging that shouldn't necessarily be sitting next to them at school or work. Others in the state do have these opportunities. The caveat for these individuals is their trach or their trach and vent, which does not mean that you are in hospice. It means that you should have the right and the choice to live as independently, live, play, and work independently in the community, just as others have the choice to.
Okay. Was it your son who spoke last month?
No, it was Donna Miller's son, and I do not
Okay.
think they're on today.
Okay.
His name was Justin Miller, and he actually is a self-advocate.
Yes. Yeah, I know Justin. He speaks through a machine. He did a wonderful presentation last month.
He is really fabulous. He has so much potential to be you know, he'd love to be an artist out in the community a lot more. So
Yeah. Well, excellent presentation.
thank you.
Before I move on, is there anything else you'd like to add, Tina?
Just please consider us. It's something we've been working on for a long time and hoping for.
Okay. Thank you so very much.
Hi, Jennifer, if I could just
Yes.
step in real quick. So just want to make sure for the sake of time, I don't know that we will have a time for all, like a recap of all presentations, although we do appreciate it. But welcome any questions the committee members may have before voting takes place.
Okay,
Yeah, hopefully that makes sense. Thank you.
that does make sense. Yes. Whatever works best for the group. Are there any topics anybody wishes to raise about a particular presentation or to discuss a particular topic? If the group would like, I can do a brief rundown of the title of the presentation. That would be concise. Would that help? I'll go ahead and just do that briefly. There was, like there was Tina's presentation. The next one was Dr. Jeff Meltzer, the OBGYN. He was talking about the prenatal screening for Down syndrome, trisomy 21, 18, and 13. The next one was the Utah Association of Community Services. There was Jim Jensen, Neil Allred, talking about intellectual disabilities and supporting their organization through inflation. The next one up was two genetic counselors, Craig Adams and Jim Kohler. They talked about an OncoExtra TRA profile, a genetic test that looks like it is more reliable in testing bladder, lung, colorectal, and breast cancers. I know this is very brief, so if you have any questions, raise your hand, or if you have anything to add, jump in. Okay. The next up was Tom Forty. He was talking about electrical growth bone stimulation in situations for bone fractures and spinal fusions. This procedure stimulates osteoblasts or cells that they may bump into each other and create new bone cells that allows a space for new bone to grow. The next one up was Marianne Ness. I believe she was representing EPAS, EPAS. I'm not quite sure what that stood for. However, their organization helps people stay at home and keep them out of institutions. Their pay for their workers is not high enough at this time. I think it's $13 an hour. And they put the proposition up really to help people who are at risk of being institutionalized. Their services help prevent that from happening. The next one up was Dr. Jennifer Mitchell and Dr. Jennifer Middleton with the Utah Children's Center of Utah. They offered trauma-informed care and mental health services to ACE children, that's children who have experienced adverse childhood effects. Currently, they are reimbursing at a loss or not receiving any reimbursement at all. The next speaker was Rachel Craig with the Association of Community Health. She's asking for an increase in the income threshold for pregnant women. Currently, Utah falls 47% in the nation for I'm looking here on my chart. My apologies.
If it's helpful,
Yeah.
I can just tell you it's they're 47th. Utah's ranked 47th out of all the states for the lowest income threshold for pregnancy Medicaid.
Thank you.
You're
Thank
welcome.
you. Okay. Next one up was Dave Park with Homestead, Home Care and Hospice. He was talking about the ACBS aging waiver and new choices waiver rate increase request. This again, his organization is helping people stay out of institutions, saving Medicaid a lot of money. Without the assistance, they are finding that running their organization is not sustainable, and they are at risk for cutting some of their clients who are on a home hospice and home health. The next one up was Erica Grodwell. Sorry if I'm mispronouncing this. Gradwell. She's a dietitian. She was talking about the Simply Sick food thickening gel, advocating for those with swallowing disorders. They can include stroke patients, individuals with brain injuries, or who've had surgeries that affect their ability to swallow. If in their recovery they're not getting the appropriate consistency of food, food or liquid can get into their lungs and they are at risk for developing pneumonia. Because the aspiration can cause pneumonia. So she is advocating for this Simply Sick, I want to call it just a food thickener to help patients get their food down and swallow their food. It is the last step before providing a feeding tube. Again, jump in anytime if you want to add anything, since I'm just doing such a fast, brief overview. The next one up was Andrew Rick with the Disability Law Center. He was advocating for a living wage for peers, affordable housing for Medicaid enrollees. Currently, there is a waiting list for 6 to 20 years. And he helps a lot with the behavioral health component with the Disability Law Center. And also with, and how do I say this, like the certified peer support specialist out there working in the community as well. We would just like to see a better wage for those individuals. Again, that's pretty rudimentary for Andrew's presentation, but for lack of time, I'll jump to the next one. It was Complex Rehab Tech, presented by McKay Lee. This is to advocate for those who need medically necessary equipment and who have complex medical conditions. The next person up was Mircea Devrisian with Camp Christopolis. They work with children with disabilities and have a lovely camp up Emigration Canyon. I don't know if you've drove past it. A lovely little place. There's a place for children with disabilities where they can go for like a summer camp. Some of the kids have cerebral palsy, some have fetal alcohol syndrome. They provide behavioral therapy, and it provides a respite for their caregivers. The next one after that was Elena Dickas or Alina. I apologize if I'm mispronouncing your name. And there may have been a Dr. Neil Davis co-presenting. They're with Primary Children's Hospital. They work with medically complex children who are enrolled in Medicaid. The children have they have chronic conditions. They need to have 3 medical conditions affecting 3 organs, to my understanding. Cognitive difficulties. The children also suffer from rare pediatric diseases. They provide mental health and behavioral health. also for ACE children who have suffered adverse childhood effects. And then moving on to the very last one. I have Derek Grass and Will Hancock. Derek Grass, I believe, is a pharmacist. They were advocating for an obesity medicine, also for diabetes and hypertension. I can't remember the name of the medicine. I don't know if this is the name of the medicine or the name of the manufacturer, Novo Nordisk. Oh, Mircea, you have a question.
I do not have a question. I just wanted to briefly just, thank you for the nice recap on Camp Christopoulos. I just wanted to add the fact that we serve children, teens, and adults with special needs and disabilities. And I would add that obviously a majority of them are people with cognitive challenges, and obviously, we have also physical challenges, and we hire registered nurses on campus during all our sessions, and as many of our participants that we serve require special assistance. They have feeding tubes and many complicated, procedures, and we're the only provider of services to the state of Utah through DSPD for this type of services.
Okay, thank you. I have drove past up that Camp Immigration Canyon, and it is lovely. Thank you for your clarification.
Thank you so much. We invite anybody to come and visit with us. We want as many people in the community to know who we are and what we do.
Okay, thank you.
Thank you.
All right. Is there anybody else who would like to jump in on the discussion? David Moore and Kyle P. Yes. Do you have a question?
Yes. So hi, my name is Kyle Prosen. I'm calling on behalf of Natera, and I wanted to offer, I guess, just 2 points of clarification. 2 points of clarification real quick. So Dr. Meltzer, while he is an OBGYN part of Natera, our presentation for non-invasive prenatal testing is for any NIPT provider, and there are several NIPT providers in the state, several of which provided letters of support, which we shared with you. And since our meeting, there has been an additional state that has covered or has announced coverage for non-invasive prenatal testing, bringing the total number of states that cover non-invasive prenatal testing, total number of state Medicaids to 48 states. Thank you.
Thank you, Kyle. All right.
Hey, Jennifer, can you hear me? This is Davis Moore.
Okay, yes, I can now.
Thank you.
Sharon, can you
And
hear
so-
Davis?
Yep,
Yeah.
I can hear him. Thank
Okay,
you.
okay.
So I had a question about the Wegovy, the medical management of obesity or chronic obesity. It's not been available for almost a year, and so I'm not sure why they're trying to market it more if it's not even available for patients. I know that we've tried to reach out to manufacturers to find out when it will be available, and they didn't give us that information. And so I just don't know if it's a wise decision to put money to something that's not available.
Okay. Thank you so much,
Hi.
Davis.
Can I
Yes.
jump in here? This is Shannon. I am with Novo Nordisk and
Yes.
with part of the presentation. So I wanted to just clarify, one of the things that we are working on is just the coverage for patients on Medicaid to have access to treatment for medical management for weight loss, not a specific product. Although we do
Okay.
our manufacturer and do supply a product, but it's to address the coverage in general, because there has been historically a policy block. So that's our objective, is to raise the issue of having coverage for patients that are on Medicaid instead of having a block. Secondly, just to address the question, you're right. We have had manufacturing issues, but part of that has been, in respect to demand in the marketplace. The product is available. It's just we're trying to meet meet the demand in the market. So we do have reduced access in the course of the last year on the lower doses, just to make sure we can maintain patients that had already started the product. So I'm happy to provide an update on our product specifically if you're interested in knowing about manufacturing and meeting the demand in the market. But really the purpose was for Novo Nordisk to address the access to obesity treatment for the patient population. Okay. Does that help? Yes. Does anybody have any comments?
I do. Hi, Jennifer.
Yes,
it's Stephanie. Yeah, I appreciate Davis's comments. I'm concerned just like Medicaid members' experience of obesity is going to be really complicated. The overlap of like social and structural determinants of health are going to be significant, and you know, additionally, I mean, eating disorders are lethal, and we don't really know if some of these medications cause eating disorders. And so I do think that we should be really careful about like moving rapidly in an area where we don't have a lot of research on like potential unintended consequences. And I think when we've, you know, we can look back at our history of like some pharmaceutical products that have been pushed and unintended consequences that cause lethality on that. So I think we should be really careful about that. That presentation was concerning and surprising to me as well. So I would just like for us to have some caution and maybe even ask the health department to like do a study about what we know about like obesity within the Medicaid population and how we can maybe solve it through some like upstream preventions and some other things before we like move into a pharmaceutical approach that might have some unintended consequences. I recognize that it might benefit some people, but we just don't have enough safeguards, in my opinion. And from like a member perspective, there's just going to be a lot of issues, I think, with like how that gets marketed and handled, you know, at the community level. So anyways, I also would just like to see the health department do an analysis or something with, you know, what is going on with obesity and Medicaid members and what other options can we go forward with before jumping directly into that solution. It's just my, but thank you for the presentation. Just, I wanted to share my perspective. Thanks for the time.
Thank you, Stephanie. I see two more raised hands, Corey Holdaway, and then a
Yes.
Jennifer Brinton. So Corey, you could go first.
Yes, thank you very much. I just wanted to clarify the home health and hospice ask that Dave Park made. It wasn't specific to his business. That was an 1115 waiver request for an increase on Medicaid funding across the board for all home health and hospice agencies that provide services for and right now they're significantly underfunded. So I just wanted to make sure that the committee was aware that that wasn't just one company.
Yeah, thank you so much, Corey, for clarifying that. Yeah, it isn't just home instead, it is many companies. Thank you. Jennifer Brinton, you've raised your hand.
Yes, can you guys hear me okay?
Yes.
So I'm one of the physician representatives to the MAC, and just wanted to touch base about just a question about medications and safety. We do have that drug utilization review board through Medicaid, where we do have pharmacists from the University of Utah present on new medications and discuss safety. So we do have a method and a mechanism in place for reviewing safety of new medications, if that's at all helpful for the team. Thanks.
Okay. Thank you so very much. Are there any raised hand? Corey, did you raise your hand again?
No, I'm sorry. That was a mistake.
Oh, okay, no problem. Any other questions? Okay. Sharon, yes.
Yep, so it looks like it's wrapping up. I just want to encourage the committee members, if you have not voted yet, please do so. That way I can finish tallying the vote during the meeting and give the results at the end of the MAC meeting. So please email me if you're having any troubles. You can do it on RedCap. I did stick the link in the chat, or you can send me the ballot via email. So thank you. Thanks, Jennifer.
Thank you, Sharon. All right, with that, if it's all right, I'm going to move on to the third agenda item. This is the public hearing for the 1115 demonstration waiver amendment, dental services, family planning, and chronic condition support by Laura Belgique. And Stephanie, I see you've raised a hand.
Sorry, I just
Yes.
have one more quick question. I'm so sorry. Thanks
Yes,
for
Stephanie.
letting me jump in. Just one more budget question for the department. I know last year, and maybe my memory is off, but I'm just thinking about this particular legislative session. The biggest Medicaid budget item was from the hospitals, and I don't remember them asking for that at the MAC last year. And I realize they don't have to; they can go about it their own way. But I'm just wondering if there are big budget items like that that come to the attention of the agency over the course of the next several months before the next legislative session, is there a way that y'all could just maybe like bring that up in MAC, or just like let us know that like those things are popping up? And maybe you did. I have like a really bad memory, but I did look at my notes and I didn't see anything. So I did want to just like ask and see if Brian or someone else could just say if that's something that y'all could maybe bring up in future MACs if you do hear of big budget items that are, you know, being asked of the Medicaid budget, even if it's like the federal side, not necessarily the state side, but I still think it's relevant to like this committee. So I just wanted to ask that.
Okay. Thank you again, Stephanie.
So, yeah, I'm wondering if Eric, it may be more appropriate for you to speak on this, but I mean, the short answer is that the development of the governor's budget is a private exercise. So that, in so many words, that is not possible. I do think the thing you're talking about was a Senate bill, which is not even part of the governor's budget, would be part of legislative discussions. But Eric may feel free to add any more.
No, I think you addressed it correctly, Brian. Thank you.
Okay, thank you.
Okay. Any other comments? All right. As I was speaking about earlier, Laura Belgique is up to talk about the public hearing for the 1115 demonstration waiver amendment. Is Laura here?
I am here. Thanks, Jennifer.
Oh, hello.
Hi.
Okay, I'll turn the time over to you.
Thank you. So I'm here today to share 3 1115 waiver amendments that we are working on. And as usual, I will read through the summary documents, which you should all have received in an email. And I think the easier thing to do today would be to go over all 3 summaries first before opening it up for comments and questions. And we do have our subject matter experts on the call as well to help answer questions that come in. And as a reminder, the process is that we collect your comments and summarize them and submit to CMS as part of our application process. The comments are taken into consideration when CMS goes through the approval process. We will be submitting these amendments by the end of July. And to note, the 30-day public comment period began on June 7th. And so today, and it goes for 30 days until July 7th. So today is not the only day to submit comments. You will have the opportunity to provide anything additional through the various means that are listed in the full amendments, which are on the website. And that is through email, phone, mail, and through the 1115 website. So I'm going to go ahead and get started, and I'll share my screen here. We'll start with, this is Senate Bill 19, which is dental services for Medicaid eligible adults. This was the result of Senate Bill 19, which was run through this year's general session, titled Medicaid Dental Waiver Amendments. This amendment seeks authority from CMS to provide dental services to Medicaid eligible adults. As far as the eligibility, individuals under this administration must be Medicaid eligible individuals aged 21 and older, and the following eligibility groups: aged, blind, and disabled, parent, caretaker, relative, targeted adult Medicaid, former foster care youth, adult expansion, the spend down program, breast and cervical cancer, nursing home, the 1915C waiver programs, refugee medical, presumptive eligibility, and transitional Medicaid assistance. This demonstration does not include individuals 18, 19, or 20 who will receive dental benefits through the EPSDT benefit. As far as the benefits goes, there are no changes to the dental benefits provided to eligible individuals under this amendment. The individuals will continue to receive state-planned dental benefits with services provided by the University of Utah School of Dentistry and their associated statewide provider network. As far as the time frame, we intend to implement the coverage as soon as possible after approval, and we expect approximately 243,247 individuals to be eligible if the amendment is approved. I'll move on to Senate Bill 133, which is Family Planning Services, and this amendment seeks authority from CMS to provide family planning services to a specific population. As far as the eligibility goes, individuals must meet the following criteria in order to qualify. They must be a woman or a man age 18 and older, have a household income at or below 185% of the FPL using MAGI methodology, which includes a 5% FPL income disregard. They must be a U.S. citizen or a qualified non-citizen. They must be a resident of Utah and not in a public institution. And they must be ineligible for coverage under any other Medicaid program. As far as benefits, they are family planning visits, FDA-approved methods of contraception, FDA-approved vaccination for HPV, laboratory tests done through an initial family planning visit for contraception, including pap smears, blood counts, and pregnancy tests. Additional screening tests may be performed depending on the method of contraception desired and the protocol established by the provider. Additional laboratory tests may be needed to address a family planning problem or need during an inter-periodic family planning visit for contraception. Drugs, supplies, or devices related to women's health services, contraceptive management, patient education and counseling, and testing for sexually transmitted infections, and treatment for sexually transmitted infections. As far as the time frame goes, again, we intend to implement the coverage as soon as possible after approval, and we expect approximately 5,000 individuals to be eligible if the amendment is approved. Moving on to the third, this is chronic condition support. Again, this was a bill that was run through the 2023 session, Senate Bill 269, titled Chronic Condition Support Amendment. This amendment request seeks authority from CMS to provide additional Medicaid services to fee-for-service eligible enrolled individuals with chronic qualified health conditions. As far as eligibility goes, they must meet the following criteria. The individual has to be diagnosed as having a qualified chronic health condition, and the individual is not enrolled in an accountable care organization. As far as benefits, if approved, members will be eligible to receive a telemedicine platform for the member to use, an in-home initial visit to the member, daily remote monitoring of the member's qualified condition, all services in the member's language of choice, individual peer monitoring and coaching for the member, available access for the member to video-enabled consults and voice-enabled consults 24 hours a day, 7 days a week, in-home biometric monitoring devices to monitor the member's qualified condition, and at-home medication delivery to the member. Again, we intend to implement as soon as possible after approval, and this would be operated as a 3-year pilot program. And we expect approximately 1,350 individuals to qualify if this amendment is approved. So I will now open it up for public comment.
Thank you, Laura.
Thank you.
Can I ask a question that you might know the answer to, or maybe
Sure.
not? So with this waiver, because it's a sole source kind of thing, or like it's like a single entity will be contacted, whatever you want to call it. So would patients, so they wouldn't be like in contact with their normal like provider, right? So this would be like kind of like a secondary almost provider kind of deal, right? If that makes sense.
I don't know, Jolyn or Brian, can you speak to that?
Yeah, thank you for the question, Rachel. No, it wouldn't necessarily remove them from any other provider choice or anything. We view this as like an opt-in, that it would open up additional peer mentoring. It's largely, I think, what the design is through an application on a smartphone to allow additional peer mentoring resources and everything, but it would be an additional benefit beyond what is already covered.
Yeah, I didn't think that they were like getting removed, but I was just like confirming that it would be like a different provide, like I don't want to use the word provider, but a different support that's like outside of like what might be their normal primary care provider. That's like kind of just what I just wanted to confirm that.
Right.
And then I guess this is more of a comment, and Ouch will also submit written comments on this, because this does seem like it's going to be very technology based and it is supposed to be a statewide demonstration. I would just keep in mind some of the broadband barriers for rural and frontier folks, just because they might not be able to utilize this benefit in the same way that someone that is in an area with better internet is. But we'll keep that in our comments too. But I just wanted to bring that up specifically.
Yeah, thank you for that input. We welcome your comments.
I noticed 2 additional hands went up, Jennifer Lloyd and Pushyami. Do both of you have questions?
Rachel primarily addressed the questions I had. Thank you.
Okay, thank you, Jennifer. And Pushyami?
Yeah, hi. I just wanted to give an intro, like it's not a question. So I'm Pushyami Ajirapu. I work as an oral health policy fellow at Utah Health Policy Project, an organization committed to strengthening Utah healthcare system for undeserved communities. We kind of feel that oral health is an indispensable element for an individual's overall health and well-being, and dental cavities and gum diseases can be impeded in initial stages with early preventive measures, and yet dental caries is most common chronic disease in United States. No inclusion of dental coverage under regular health insurance plans is a major constraint to access the oral health care, limiting oral health promotion. Medicaid should cover these full spectrum of oral health needs to ensure whole body health of patients. Cost coverage, fear of dentist, social determinants of health, as well health inequity, limited awareness on oral health significance are potential barriers to improved oral health among the diverse communities in Utah, which can be subdued by planned addressal and dental coverage expansion of Medicaid. We at UHPP strongly believe in the need for oral health equity, dental coverage, and strategies to build awareness on oral care. We strongly advocate for Medicaid adult dental waiver to help and support Utahns in improving their overall health outcomes. Thank you.
Thank you so very much. And thank you for your work with UHPP.
Thank you so much. Yeah.
Yes, you do wonderful work. Were there any other questions or comments? All right, looks like we will be ready to move on to the next agenda item. It is the director's report to include the PRISM update and 2 new CMS proposed rules. And Jennifer Strohhecker will be presenting.
So actually, last minute audible, I will actually be giving the presentation. Jen is
Eric Grant. Okay.
Yeah, yes.
Okay.
Jen's actually in Washington, D.C. She was able to hop on the call. So if we go too far off kilter, she'll be able to step in.
Thank you so much, Eric.
Oh, you bet. First off, I just wanted to add a notification on our submission of our postpartum coverage waiver. We did submit that to CMS on the 18th of May. It's currently sitting in a public comment period, so just wanted to make the committee aware of that. So on to PRISM updates. So as you know, we wish we had unlimited resources and could address every issue as quickly as the providers would like us to. But since go live, we've identified 1,170 defects. Of those, we've been able to correct or resolve 61% of them, which I think is a fairly good resolution rate. We have another 23.2% of them scheduled for release dates in the next few months. And the remainder are still items that we're researching and working through. So we've made great progress, but do still have a distance to go on making the system stable for normal operations. Our next big release is scheduled for July 13th, which will contain several defect resolutions. A lot of those focus around managed care plans. So any questions on PRISM? Happy to entertain those right now. Wow, okay. Happy to move on to CMS rules. So CMS has released two proposed rules that are fairly impactful of the Medicaid program. The first one is a managed care rule, which contains a lot. It's very, very long. It's thousands of pages. We've been combing through it and trying to develop a really brief synopsis of what's contained there. So I'm going to try to do it in just a few sentences. One thing they're proposing are appointment wait time standards. Normally, we've had time and distance standards where it's required that a provider be within so many miles or so many minutes of where an individual lives. This new rule would change it to actually appointment wait time, where they would be measuring how long it took for an individual to get an appointment. In conjunction with that, they're proposing the use of secret shoppers to validate those wait times. The rule also would require uniformity of Medicaid websites for both Medicaid and CHIP program across the country. There would be some changes to directed payments and specifically contract requirements around directed payments. Also, additional standards and reviews on medical loss ratio calculations for managed care plans. Some clarification on in lieu of services. And finally, some updates to quality assessment and the rating systems for quality for Medicaid. Kind of a quick synopsis on that. It makes it a little more in line with how Medicare has done quality. So it's a lot of changes for Medicaid are packed into this rule. And right now it's open for public comment, and we are working on it as a state, preparing our feedback for CMS on this rule. The other one that they've recently released was around school-based services. It requires some changes nationwide, but fortunately for Utah, we're largely unaffected by it because we went through quite a large state plan amendment over the last couple of years in our school-based program. And a lot of the things that were mentioned in this rule, we are already compliant with. So we're very happy about this and glad to be ahead of the curve on this one. Let's see, I think Stephanie made a comment. Yes, we would be willing to share what our comments are on those rules. You bet.
Okay. Eric, thank you so much for filling in.
You bet. Happy to do so, Jennifer.
Yes. Are there any other questions or comments before we move on? Okay. Next up is Jess Nelson with the Unwinding Continuous Medicaid Eligibility Update.
Good afternoon, everybody. I'm going to present my screen here just momentarily, so you might have to give it a second. I know it's been hesitating a little bit lately as we do this, but hopefully you'll see a screen popping in shortly. I'm seeing it. I hope you are seeing that. All right. This is our monthly report. So we are entering month 4 of unwinding, which is removing or slowly reviewing each and every case on Medicaid over the period of about 12 months to try and, I'm getting a little feedback there, sorry. So we're trying to go through each and every case to make sure that they continue to qualify for Medicaid. As many of you know, We've held cases open during the public health emergency, and that requirement was removed in December, effective in our case for April. So as of April 1st, cases that are no longer eligible will be moving on to either the next phase of Medicaid or maybe to the CHIP program, as you'll see in a moment, and or maybe onto the health exchange. So this is some preliminary data. And the first time, I think, in the MAC meeting, you're starting to see on the larger graphs some of the declines to the Medicaid enrollment. So as you can see from this chart, this shows our height was at 536,000 people last month in April, or sorry, 2 months ago now in April. And you're seeing that decline for May. So we're in June, of course, and we're reporting on May information. There's a little bit of a lag time each month as we meet. So you're seeing there that first decline from 536,000 total individuals to 508,000 individuals. Over time, this chart will decline down to zero as we move through each and every case to make sure that they're all, let me rephrase that. This is our total enrollment. This will not go to zero. This is our total enrollment for Medicaid. A graph I'll show you in just a moment will be going down to zero as we complete the backlog or the work that needs to be completed. Sorry about that little snafu there. In the first month, in April, Utah experienced about 35,000 members that left us during that period. In the month of May, we saw 39,000 closures overall on May 31st. That is fairly expected, meaning that we do know that we have more people on Medicaid than likely belong there at this point in time. And again, as we go through the cases, we have prioritized them to make sure that we're looking at those that we believed to be ineligible up front to try and get those folks sorted out to where they go. And I'm excited to show you a little bit of our dashboard in just a moment. The reporting that's happening with CMS, I just wanted to call this out. We've had a lot of actually grammar requests, and we've had people calling and asking, even the news media, interested in these reports. All states are reporting information to CMS. CMS is not looking at the data as I just presented it to you. They're not looking at how many people left the Medicaid program month to month. Rather, they're looking at of the total population of Medicaid, for example, that had a review in the month of April, how many of those folks left the program in April? So it's a smaller or subset of the data overall. But with all those grammar requests, we did get approval recently to add that information so that anyone that wants to see that can do so from our website. And I'll give a little plug for that in just a moment. It is not there yet, but hopefully by the end of this week or early next week, you'll be able to see all of the reports we've submitted, and we'll continue to submit on or about the 8th of each month. Again, this is a subset of the data, so please don't think that that is everybody that's being considered. It is simply those that had a review actually due in that particular month. So you'll see April, you'll see May, and then shortly you'll see June as well. Hopefully that is helpful information for you. But we are making those publicly available as soon as we can. And again, those numbers I gave are written down here for your reading pleasure. And Daryl, UHPP, you're wanting to clarify on the 39,000, that was 35,000 in the month of April that ended on April 30th, and a new 39,000 that ended on May 31st. So combining that to about 74. And Brian, please jump in. Thank you.
Yeah, no, you're exactly right, Jeff. I just wanted to add additional clarification that many have already returned, and which is not the perfect scenario, but at least they have been able to return to the program and resolve the lack of information and get re-enrolled in Medicaid. So that was like at the end of the month, and then additional eligibility activity happens after the end of the month.
Thank you for that, Brian. And I would say that that is very much expected as well. Over the period of the public health emergency, we essentially trained a lot of our membership that if they didn't respond to our notices and if they didn't do their renewals, that nothing happened. Their case did remain open. So that certainly was confusing for some. And while we have tried to message that this review matters and this one does count and will have some impact, there are several folks that until they get a true closure letter won't react to what they're seeing. And I think that's what Brian's referring to exactly. As they get that closure letter, they are then coming back to us, and we're already seeing many of those re-enroll. Let me jump to some questions right here before I show you the dashboard. I see Stephanie first, if that's okay.
Thanks, Jeff. Thank you for this. I know y'all are doing a lot of good work and I appreciate it. I just wanted to I probably will have several questions throughout this presentation, but to Brian's comment just now of when he says that many, I tried to write it down, but when he says many have returned, do we know percentages? I'm just trying to kind of like reconcile this with some comments that Kevin made to the legislature yesterday, because it sounded to me like he was saying that if people are not filling out their paperwork, his assumption, and he was representing DWS, I believe, was that they don't qualify. But if we have people that are falling off and then they're re-enrolling, they do qualify and they didn't get their paperwork filled out to what you said. Yeah, I mean, probably because they haven't had to fill out paperwork in a few years. So I'm just trying to kind of make sense of like those. It just seems like, I don't know. It seems like it can't be, I'm either misunderstanding something or it both, like, it can't be true that like the majority of people are just like don't qualify and that's why they're not filling out their paperwork. If there are many people who are actually re-enrolling, that would tell me that they are still eligible and them not filling out their paperwork isn't. I think a legislator even said almost all of them probably don't qualify. And I just like that doesn't seem to be true, right? Does that make sense, Jeff? Are you following me?
If I may, Jeff.
Yeah, please go ahead.
Stephanie, I think that some clarity on this is probably required. Usually, if a customer does not complete the review or does not participate with the review process, then the assumption is that we are unable to recertify and the customer would be ineligible. When the customer does complete the review, we will make the redetermination based upon the information that's available to us. And a lot of time, customers get a reminder that their case is scheduled to close, and they at that point complete the review. So we continue with the process when the review is submitted. I think it might be a foregone conclusion to say that most people are not qualified. The truth remains, some of those folks no longer qualify based upon our rules, but we still have to take a look at every review and redetermine eligibility.
So Stephanie, if I may, I'm going to be showing a chart in just a moment here that shows kind of a breakdown of where we see people going from the CMS data that we are turning in. I think that might be a helpful graphic here. I'll quickly get to that. I just really wanted to pause here for just a moment. This is the Medicaid.utah.gov unwinding webpage. And on this webpage, there's a lot of information. It looks like a great government site. I get it. A lot of information here. But if you scroll about midway through, and there is more information even on timelines, et cetera, down below. But in this area, I want to highlight this little blank spot right here is just reserved for those reports I mentioned earlier. Well, you'll be able to dissect the CMS reporting if you'd like to. That's where we intend to add those. But I'm clicking on the unwinding eligibility dashboard, which does have some updates to it, and we'll show a little bit more about what's being asked right now. And all of a sudden, these graphs get a little bit more interesting. So there are two graphs I'll show you, and I think it will help Stephanie with what you're asking. This shows the work, and this is the graph I alluded to earlier. This is meant to show the work or the backlog of cases that need to be looked at and how they will be represented over time. You're seeing that the high point there was in March, which is when the unwinding started for DWS to start looking at case work. That was our high watermark right there. If you hover over these lines, you'll see data points with actual numbers associated to them if you want to see more detail there. This is showing the total work. And as you can see, over the past 2 months, this is from from March into May, the other M month. This shows 2 months of activity of how many cases were looked at. And then that's further broken down by how many cases were being artificially held open versus those that had been completing reviews already and were being held open. But all of these cases, as they're reviewed, this number will eventually go to zero. This is the mountain of work, if you will, that's in front of us that needs to be completed over the next 12 months. Now let me go to what you were asking about, which is the review outcomes. And I'm selecting on these tabs. I don't know if you can see the mouse very well, but there is a review outcomes tab. This data, again, right now we are pulling from the CMS reporting, but we believe it to be consistent with what's occurring in any given month. So I'm going to review these colors for you a little bit. There is a key there that you probably can barely see, but I'll review what each of these are. I'll start at the bottom, the yellow and the green. You can call them what colors you like, yellow and aqua. So the first two blocks at the bottom, these are folks that were renewed by DWS. They were looked at. and these cases were approved and are moving forward. How they're approved is why they're in different colors. The yellow indicates that the review was done without the person's participation. The green was with the person's participation, usually through a pre-populated review form. So the bottom block, about 42% of cases overall, are staying with us as we go through them. And that answers part of your question, Stephanie. The second part, I'm going to jump to the top. There's a little sliver up there of purple on my screen, I hope it's purple on yours, that shows people that have not yet been resolved. And that could be for a few reasons. We've started looking at their case, we've asked for more information, that's not yet come back to us, or we're still processing it, or the person's asked for more time. There's a lot of reasons the case might still be pending from a previous month. So that's a small little sliver at the top. Then I'm going to talk about this light blue and dark blue to me, but maybe dark purple. These two colors here, which are talking about those that have closed. That is so, and this first graph I should have mentioned is all of April. The second graph is all of May. So in April, you'll see here these two blocks, and the largest block really is that dark purple blue color, which are those that were closed procedurally. The smaller number, the little light blue in the middle there, are those that were closed because we truly know that they're ineligible. So now I'm finally answering your question, Stephanie. Of those cases that closed procedurally, so we didn't get the information back, that's what we're able to tell you. We can say we know we had a large chunk of people that did not information to us. We tried to look at them and approve them on our own. We weren't able to do so. And because information doesn't come back, it does not mean that they're not eligible. It simply means we don't know. We don't have that paperwork. So until we have that paperwork, we can't decipher if we should send them onto the exchange, put them onto a different Medicaid program, or move them to CHIP. And that is hard for us, of course. This week, CMS put out some new guidance to us and some new helpful guidance, we think. It was 6 pages long. We're still dissecting it a little bit, trying to figure out what we can do with it. But it's talking about that dark blue box that you're seeing there. What can we do differently? How can health plans help? How can others help us to look at these cases, not look at the cases, but to help us get the information back so DWS can look at those cases? So we have some internal deciding to do, and I think we have certainly some advocates out there that will have some ideas as well, and that's great. That's what we'll need to do next to see, can we reduce that number? I think we're all okay if we have actually looked at the case and recognized the person's no longer eligible and we're moving them on to wherever that next phase may be. I think most of us are okay with that. That's what should naturally occur. What all a little bit of heartache, I think, is that we don't know what should happen here. And for the health plan specifically, we can't send these folks to the exchange, so we can help with that. And again, trying to get that information back has been difficult or proven difficult. Before I go to you, Brian, let me just show one quick screen and I'll jump to you. This graph was not interesting at all before, really. It was showing very small numbers of children that were moving between Medicaid and CHIP during the last several months of the public health emergency. But look what happened in the month of May. We're starting to see that faucet turned on, if you will, that shows we have some children now moving from the Medicaid arena into the CHIP arena. And as the CHIP director, that's exciting for me. So we're excited to see that natural movement occur. So there is some good that is occurring, and I don't want it to all sound doom and gloom. There's some good movement occurring here. Jumping back to this screen, you are seeing that there is a large chunk of folks that remain eligible with us. Now let me jump to Brian. I'm sure you have some questions. Go ahead.
Yeah, no, and thanks. We're excited about those jumps as well. You mentioned the CMS recommendations that the department is still kind of looking those over. Do you want any kind of recommendation from the committee as to how we feel about the recommendations? Is it something that we should make a motion to have the department accept CMS recommendations, or?
I would leave that to the committee to make what recommendations you will. I do have them here if you wanted to quickly see. You're not going to be able to read all of this. As you can see, it is 6 pages long of different ideas of things the state may or may not consider to try to reduce that number of folks that are falling through the cracks or having those paperwork issues. Again, part of the understanding there, what Murrah said was also accurate. There are some people in there that recognize they're probably not eligible and are not completing their paperwork, because why do that if you know you're not eligible? The other side of that coin, though, certainly is If you think you're not eligible, you might be wrong. We count income in funny ways for some of our programs, and we also have the opportunity to send you to the health exchange and at least start that process for you. Now, people don't have to wait in line at DWS to do that. They can actually jump straight to the health exchange and do that on their own, and some may in fact be doing that. We don't get a lot of information back to the state from the marketplace, and anything we get is going to be probably months down the road. But I think you bring up a good point of, are there things on there you might want to do? One of these says, hey, can the health plans help fill out some of the paperwork? I think that might be one you might want to recommend from your perspective. But as far as that, I think it's to the committee.
Yeah, and I think maybe what we could do is just make sure that all committee members review the options that you listed there in those 6 pages, and maybe we do come back next meeting with a recommendation and perhaps a motion to have the department accept those recommendations. And I don't want to put added pressure on Murris, because I know if we did that, it might make him stir a little bit more. But I think some of these are so important that we haven't explored as a state yet. And so I'd really like to see the department take these on.
Are there other questions about? Oh, go ahead, Brian.
I'll just, I mean, certainly we welcome that, and the committee may act. With a couple of clarifying points, we have taken some of these flexibilities already. Like
correct.
Around using asset verification system, or like if it takes too long to return information from the asset verification system, proceeding anyway, and individuals with zero income. So recognize that it was a national email that CMS gave, not specific to Utah. Some of these have already been implemented. But again, we'd welcome committee action if you so choose.
Yeah, I appreciate that. That's what I was thinking. I know some of these things the state and the department have already implemented. I think I would be looking at those that they haven't yet looked at.
Appreciate that comment. And I would also add that the information you're seeing here is not exactly what we were hoping to show you long ago when we first talked about this data dashboard. We are in the background still working with DWS to perform a very, very difficult query to follow, if you will, a giant cohort, all of the Medicaid population over the course of this 12 months and determine where people went and how. This representation you're seeing today, again, is based on the CMS reporting, which is a subset of that data. We'd like to be able to give you all of the data because it might change the colors or the amounts in these colors a little bit. So we are still working on that in the background and hope to have improvements as we move along through this process.
Yeah, I think that there were so many, we were surprised to see so many individuals coming off the rolls in these first 2 months. And I know that we were expecting a larger number in the first couple of months, but we didn't think it was this large. So yeah, I think for a lot of us, we want to make sure that every family and every member get the opportunity to stay on the program. And so we want to be careful about how we look at that and what we do to help these families and these individuals stay eligible.
Yeah, Brian, and just one other comment too, if I may, Jeff. This trend that we're seeing with large amounts of closures, this is somewhat reminiscent of what we used to see in review months prior to the pandemic. What happens not infrequently is that a customer forgets or fails to complete a review for whatever the reason might be, and until we get to a point where they need Medicaid services again, they don't come back and reapply or recomplete their review. So these numbers that we're seeing in terms of closures represent a population that potentially for which a percentage would be coming back when their need is reestablished, right? When they realize, well, I've lost Medicaid because I have potentially not completed a review and I now need it again, and they come back and reapply. This is trends we've seen years ago when the pandemic rules are not applied, and I don't think this will be any different.
Okay, okay. And I did hear also that if some of these individuals that lost their eligibility in the first couple of months, if they did happen to get their paperwork back in, that they would be put back on the fee for service program for a month and then switch back to the managed care plan. Is that the way you see it?
That's correct. As I had to learn that yesterday myself from Mary. She explained that that is the case. It depends on the timing, of course. If they're early enough in the process, we can get them back on the same plan. Otherwise, they may get a fee for service month for 1 month and then move back to the plan as before. And so we appreciate it. Thank you, Maurice, for that. I think that we're all striving to try and figure out how can we better review the cases that we have and to facilitate that process and make it better. As a matter of fact, Workforce Services and DHHS have been working to try and automate certain pieces of this to see if we can make the process more efficient, give workers more time to focus on the difficult cases, maybe have the system handle some of the easier cases, if you will. So we have some improvements coming down the line as we move forward through that. And those improvements are neat because they stay after all of this is over. So we're excited to see some of those things occur. We have, of course, worked with many members of the MAC committee to improve some of the notices that we get out to members. And so that work has been ongoing and been very helpful, I think, to try and get better messaging to our members. So these are things that we do care about, and we are trying to find ways to improve. Obviously, it's a very, very busy time at DWS. We're starting to see some of the call wait times go up, as you would expect. So we want to see if we can make these improvements solidly, moving forward with hand in hand with them to make sure they're good. Maurice, do you have anything else to add to that? I saw you come on camera.
No, Jeff. I think one thing that we want to also make sure folks understand is the best case scenario for us is to touch the case once, meaning we get the review, we can recertify the case, and then everybody goes on their merry way. The worst case scenario for us is having to address the case multiple times and perhaps close a case that should not be closed, and we receive an application that we then have to process. So I believe we all are striving to get the same thing and recertify these cases by, eliminating touches and getting this right the first time. So that's what we're trying to do as well.
So that is everything I had planned for the committee today. If there are any other questions, we'll take those or pass the time back. Stephanie?
Hey, Jeff. Yeah, thank you. I appreciate all of this and appreciate all that y'all are doing. Just had one final question or comment. Just thinking again about the legislative committee yesterday, and just one other comment that I heard during it that I just wanted to understand. It didn't come from you, so I don't know if you can speak to it or not, but it was said that unemployment numbers are predictive of Medicaid enrollment. And so when unemployment is low, it's expected that Medicaid enrollment will be low. And the way that it was communicated is, so I don't even know if we know the correlation between those two being like a really strong one, because many children are on Medicaid, their parents are working, anyways, we just know that there's a lot of people that are working and they have Medicaid as their healthcare benefit. A lot of employers use public benefits as a way to not pay their workers and not give their workers enough benefits. So anyway, I just feel like it's a little bit frustrating that that was communicated to the legislature, but I wanted to understand, is that a formal position of Medicaid that we do look at unemployment numbers to predict Medicaid enrollment and use that as a success metric? So if unemployment is low, we will just predict that Medicaid enrollment will be low, and therefore we don't have to worry about whether there's eligible people who are not enrolled in the program. Does that make sense? And again, Jeff, this didn't come from you, but it was something that Kevin said, and I did want to just ask if that's a formal position of Medicaid, because I just would be interested in what evidence we're using to say that.
So I'll let others maybe say the formal position, but what I can tell you is that it's an interesting indicator. It's one of many that we look at as we go through this process of trying to figure out where we think we'll go. Medicaid is not designed that it has several key functions in the eligibility actually that will actually continue benefits for a longer period of time. As you know, and I'm sure others are aware, we're looking at 12-month continuous eligibility for children. So you could have someone that qualifies as a child and currently on the CHIP program today, and as the situation improves at home, meaning that more income's coming in the family, well, yeah, maybe at the end of 12 months, they might not be eligible at that point in time. But Medicaid and CHIP are overall designed to continue cover and to provide that coverage, in many cases up to 12 months, in some cases even longer. And there's a family program that has a transitional component to it as well. So it's an indicator. It's interesting. It's not like, hey, we're at 3%, therefore Medicaid is. It's not like that at all. We do see some correlation in that when the employment is low, overall employment is low, that Medicaid may not be as needed in the community as when it is high. I think there's something to be said for that for certain. You can see that over the years in the downturn of 2008 and other times we've had economic downturns. Obviously, and when those occur, Medicaid is more utilized. That's normal. So it's out there. It's an indicator. And again, I would couch it in that interesting phase. Kevin's numbers yesterday, if you listen carefully, he was looking at January of 2020, I believe, and comparing that, the SNAP and the Medicaid at that time to what it is today. Something that's lost in that, I think, one of the components that's lost in that is the expansion we did with the adults, which started right about then and has continued to this point in time. So all of us, while we're all trying to prognosticate and figure out what the final number may be, I don't think we're going to be at 526,000 individuals like we were. We're certainly going to be less. The number probably starts with a 4, but we don't know. We don't really know where we may end up. It could be somewhere between 350,000 and 450,000. That's a very large range. But we don't know. And that's why we're going through all the cases to find that out. That's exactly what this effort's trying to accomplish. That's a long answer, sorry.
Yeah, no, well said, Jeff. I think I'd also just add that, I mean, people in a macro sense try to explain what we're seeing with other economic trends. But like to your direct question of whether there's a success measure tied to Medicaid enrollment, there's not. We, for the sake of budgeting, forecast enrollment, and we use economic indicators, but those individuals that do that are in no way tied to the people that decide eligibility policy or anything like that. So there's no success measure of we predict X number, and as long as we're around there, then it's success. That does not happen.
And Stephanie, just because it was Kevin that said that too, I think what the intent was is simply to relate that we see a correlation, looser in some program and more direct to others, that unemployment is an indicator of the need for public assistance. And that might be more true for other programs that we administer, like SNAP and financial services. However, we kind of see this as loosely connected to unemployment rate. And I think it's a valid thing to say that the more folks are employed, the more opportunities to get insurance and various options. But to what was said by Brian and Jeff, there's a loose correlation. I think the only thing Kevin was trying to display is that the need for public assistance programs and at times for Medicaid is closely related to the unemployment rate.
Okay, thank you for the clarification. I guess I would just make a request that, I think that like legislators are not super, like some of them are just like not really well informed on Medicaid, as we know. But I do worry about things so we could have low unemployment and still have a lot of people that are eligible and enrolled in Medicaid because many disabled people are not counted in unemployment data. Children obviously are not counted in unemployment data. We know that like lots of college students are, benefit from Medicaid with their children. I mean, there's just a lot of reasons why Medicaid enrollment would be higher than unemployment enrollment. And that would be like, it's not because people are cheating the system. And so I do think that there are times where legislators might walk away with a belief that I don't think would be appropriate, that people are cheating the system or that somehow employment data should be connected to Medicaid because they are making assumptions that people on Medicaid don't work. And I think that narrative really pushes work requirements, which are just really burdensome for all of you as workers to have to deal with, but they're also incredibly burdensome for the people on Medicaid and applying for Medicaid. So anyways, it's just a request that I make of like, sometimes I think that what they're going to take away, obviously we can't control what they'll take away, but I do think that it just communicated something that I thought was maybe not fully accurate about like the experience of Medicaid members, many whom are working and don't have health insurance through their employer for a variety of reasons. And even those who aren't working, there's just, I mean, this is providing like very vulnerable people the ability to get treatment for mental illness and go through a recovery program and get better from injuries and get treated for cancer and like all of these really hard things. So anyways, I just think every now and then that gets kind of glossed over in those conversations. And so it's just a request from me that you don't have to take, but it's just one that I wanted to offer anyway. But I appreciate your clarification.
You make a good point, Stephanie. All of our programs with Medicaid have an income limit to them, which almost means that we expect people to be working. It's you don't have to be unemployed to get Medicaid. That's not a direct correlation, right? I mean, certainly those that are unemployed may get Medicaid coverage, but we have many people that are actively working, and that's why we have the income limits there. So that makes some good sense. You make a good point. Other questions? Seeing none, I'll turn the time back to, I believe, to Jen. Jen, sorry.
Hello, can you hear me?
We can.
There we go. My apologies. I've had a lot of trouble with the audio today. I did notice that there were some individuals with UHPP, Matthew Sonaker, Julie, and Daryl with some questions in the chat. Did you, UHPP individuals, did Jeff answer your question?
Yeah, I think we had answered one. The one that I'm not sure was answered, Matt had a question about, do we know how many people out of those 35,000 and then 39,000 that came back on within the next, within the next, within 30 days of losing it or something like that? Do you know that yet?
So I can answer for this first month. For the month that started with 35,000, those are individuals that closed at the end of April. We've seen approximately 7,000 return already. So the updated individuals who have lost benefits at the end of April is now down to 28,000.
Thank you.
And maybe just quickly pointing out that you should expect to see that activity occur. This is one of the things you'll hear from DWS and from us as well. Over time, you're going to get better data on this. People do have 90 days after a closure to come back to us. They don't have to fill out an application. We quickly review their information as quick as we can and get them back and reinstate the coverage. So that activity, while you're hearing 7,000 today, will likely increase for that month, and you'll see the same thing occur in the future months as we go forward.
Okay, were there any other questions from UHPP? Okay.
Nope, I don't think so.
Okay. Thank you so much, Jeff, for your wonderful presentation, all the detail. I will move on now to the UTA pass utilization by Brian Roach.
Hi there, Brian Roach with Department of Health and Human Services, Medicaid. I am going to do just a very brief presentation today. This question was raised, I believe, by Stephanie a couple months ago when we were discussing the UTA utilization, and there was a question about what is the department seeing as far as how many individuals are using their passes. And at the end, Stephanie or any other members or individuals here can ask if there's additional questions. But just to frame this a little bit more, so Utah Medicaid partners with a few organizations to provide non-emergency medical transportation, or NEMT for short. That's the acronym. So UTA is one of those organizations, and it's for individuals that live in the UTA service area. That's not statewide, but in those areas where UTA does operate, for individuals who are on a traditional benefit plan and do not have access to a personal vehicle, a working personal vehicle. Then for those members, they are eligible to use the UTA system. We provide them a card that can be used, tap on, tap off. That was one of the major changes that we went through last year, mailing out approximately 25,000 cards to our members. What we have seen so far is pretty stable rides. So a little bit of vocabulary. So in UTA's vocabulary, they call the full set of rides to get an individual to their destination a journey. So they may take tracks to one location and a bus from there to a provider. In our case, it's to a pharmacy or their physician or whoever they're visiting. All of the trips to get them there is called a journey. And so the total journeys by month is shown here. What we're seeing, approximately 12,800 members have used their card. That's of about 25,000 who received the card, so roughly half. And the average journeys by month is roughly 70,000. So dividing that 70,000 by the total of people who used the card is about 5 journeys per month, between 5 and 6 per member. And that's just among members that used the card. If you divide it among everyone that had the card, it'd be quite a bit less. We're not seeing much that would give us any cause for concern about like individuals not knowing how to use their card or using it for things that are not for medical purposes. We are continuing to just look at the data and see what we can what inferences we can make, but it is fairly limited at this stage. And we have a 5-year contract with UTA. We're in year 1. We're just finishing year 1 with UTA, and we will continue to evaluate it as we go through the contract. But I'm welcome to take any questions from the group.
Thank you, Brian. I was wondering, do you happen to know if so there's a pass that UTA has that's like a low fare, reduced fare. Is everybody that's on Medicaid, do you happen to know if the eligibility is like where everyone on Medicaid would automatically like qualify for that UTA reduced fare pass? And I'm just wondering if like some of this would make a case for trying to like better connect those programs so that people could more easily enroll into the UTA pass for like when they enroll into Medicaid. Does that make sense?
I don't fully. Do you mean so that they may use their card for non-medical purposes and may be able to use like low income, reduced fare pass for other reasons beyond what we support with Medicaid? Is that the question?
Yeah.
It's a good question. We haven't explored it. So yeah, we could definitely talk to talk to UTA about that, whether being on Medicaid would automatically qualify them for that reduced fare pass or something like that. That's a good question, and I can certainly take that and get back to you.
Thank you. And then do you happen to also know, will there be any like qualitative feedback from members about how transportation, like how getting access to transportation is helping them get to their treatment and things like that?
We don't really have a design for that currently. Our resources to survey members is sometimes constrained. If you have suggestions, we'd welcome them. But yeah, we don't have like a surveying component of this, of like the effectiveness that members are seeing in utilization of this card.
Okay, no, this is helpful, and maybe I'll send you some ideas that I have, but yeah, I think this is good information. So thanks for looking at this and presenting it.
Thank you.
Are there any other questions for Brian?
Thank you. I'll turn it back to you, Jennifer.
Okay, thank you, Brian. And thank you, Laura, Eric, Jeff, for all your wonderful presentations. I will turn the time over to Sharon. It looks like she posted something on the screen. Sharon, is this the voting result?
Oh, actually, there must be a delay. It was the agenda. I was trying to show the agenda. So I don't know if you want to go over committee updates or if you just want me to jump into the results.
I will ask everybody, are there any comments or anything anybody wants to contribute toward community update?
Perhaps they're just waiting for the results. So I can jump in. So let me know when you can see. I've switched my screen to an Excel spreadsheet. Can you see that?
Yes.
Okay, great. So this is the results. The MCAC committee members have ranked the 15 presentations from 1 to 15, 1 being their highest ranking priority and 15 their lowest. So low score would be the highest ranking priority. And I will go through and read these for those who are on the phone and maybe cannot see what I'm presenting. So ranking with the lowest score of 53, so ranking in number 1 is the Mental Health and Developmental Disability Systems. Next, in second with a score of 54 is the HCBS waiver rate increase. Third with a score of 55 is ensuring infant and early childhood mental health services for Utah. Next, we have increased the income threshold for pregnancy to 200% FPL is in fourth. The increased funding for DSPD services is fifth with a score of 75. The 200% FPL was a score of 57. Technology-dependent individuals had a score of 83 for a rank of 6. In 7th, with a score of 86, we have the ACE Kids program. In 8th, with a score of 90, we have the ePass program. In 9th, with a score of 112, we have the Camp K services. We have a tie in the score for 125 for 10th, ranking number 10, with food thickener and the complex rehab technology. In a rank of 11th with a score of 126, we have NIPT. 12th with a score of 131, we have the medical management of chronic obesity and budget considerations. 13th was a score of 132, we have the OncoMap Extra. And In 14th, with a score of 136, we have the bone growth stimulators. As always, I will send out this spreadsheet to the distribution list so you all have it. And I will turn it over to Brian to kind of reiterate the process from here. So the MAC members have voted and we turn this over to the department. And so Brian, will you give a brief recap of what happens from here?
I would be happy to, but I think Eric is back, and so we're all helping out. So I think Eric will take it from here. Thanks.
Sure, absolutely. Happy to do so. Thanks. So what happens next is we as the division will take your rankings and put that together with other items that we are also prioritizing, and we will set up a list of here are the top items. There isn't an actual number, but just the top items that we as a division want to push forward to the department level. The department then does a very similar process where they take our items along with all the items from all the other divisions within the department, and they put their priority lists together, and those are forwarded on to the governor's office, who then does their own prioritization process and puts those things that they choose out of all the priorities from all the departments into the governor's budget.
Okay, thanks, Eric, for that explanation. And so Jennifer, I'll turn it back over to you.
Thank you. Are there any other comments regarding the voting results? Okay, Sharon, at this point, have we covered everybody for the meeting?
We might want to ask, we could take Stephanie's comment, and then I was just going to say you might want to ask if there's any other comments to the 1115 demonstration waiver amendments for Laura.
Okay. Stephanie, your question?
Sorry, I know I've already talked enough, but I just wanted to thank Jennifer Strohecker and the team. We had a really great member engagement activity last week in Logan, and a lot of nonprofits helped. Voices for Utah's Children paid for it. And anyways, a lot of teamwork. But anyways, it was just really great to see. And I've heard a lot of positive comments about from members that attended and appreciate how well Medicaid showed up for that. So anyways, I just wanted to say thank you.
Great. Thank you, Stephanie. Jennifer Lloyd has raised her hand. Jennifer?
Can you hear me?
There we go. Yes.
Okay, great. Thank you. On the chronic disease management, chronic condition support, is there going to be any requirement that this entity get information back to people's primary care providers, or will this be a completely separate data set basically about these individuals?
Laura, can you answer that question?
I think I could maybe step in for Laura, but I mean, no, there wouldn't be something so broad as a requirement that they share data with the primary care physician. I mean, we would certainly be subject to all HIPAA regulations and what is designed, which could include treatment payment and operations, but like hopefully that answers your question to some extent.
Thank you.
Does that help, Jennifer Lloyd?
Yes, thank you.
Okay. Are there any other questions? Oh, go ahead.
Well, no, sorry. Oh.
Okay. Are there any other questions for the 1115 demonstration waiver amendment? Okay. Sharon, would you like me to start to close the meeting?
Sure, if you would like to.
Okay.
Yeah.
Okay, yeah, I'll throw out one more opportunity for questions or any comments before I close the meeting. We covered a lot of material today. All right. I want to thank everyone for attending the MAC meeting today. We looks like we might finish up a little bit early today. Is there anyone who would like to entertain a motion to adjourn?
This is Brian. I can do that.
Thank you, Brian Monson.
Yes.
Okay. Is there anyone who'd like to second the motion?
This is Colleen. I can second it.
Colleen Kenny. Okay, thank you so very much. All right, all in favor. If you say nothing, we'll assume you are in favor. Okay. Anyone opposed? Okay. Thank you, everyone. We will stand adjourned until the next meeting on July 20th. And in the meantime, I hope everyone has both a happy Father's Day weekend and a happy 4th of July holiday. Goodbye for now.